In part 1, we discussed about the diabetes mellitus, its types, risk factors, signs and symptoms, and the diagnosis. In part 2, we will discuss about the treatment and the complications of diabetes mellitus.
Diabetes mellitus can lead to a number of complications. Microvascular complications of diabetes mellitus are those long-term complications that affect small blood vessels. The three common and devastating microvascular manifestations of diabetes mellitus are diabetic nephropathy, neuropathy, and retinopathy. Diabetic nephropathy is characterized by thickening of glomerular basement membrane and glomerular sclerosis. These changes cause glomerular hypertension and progressive decline in the glomerular filtration rate or GFR. GFR estimates how much blood passes through the glomeruli each minute. Diabetic neuropathy is the result of nerve ischemia due to microvascular disease, direct effects of hyperglycemia on neurons, and intracellular metabolic changes that impair nerve function. Diabetic retinopathy is the condition wherein high blood sugar levels cause damage to the blood vessels in the retina. These blood vessels can swell or leak, or they can close, stopping blood from passing through. All these changes can affect the vision and can even lead to blindness. The acute complications of diabetes are hypoglycemia, diabetic ketoacidosis, hyperglycemic hyperosmolar non-ketotic syndrome, and diabetic coma. Hypoglycemia is the condition where blood glucose level is below 70 mg per deciliter. This can be due to too much insulin, oral hypoglycemic agents, too little food, or excessive activity. This condition is treated with simple carbohydrates like sugar, honey, hard candy, or juice. In severe hypoglycemia, 25 to 50% dextrose and glucagon injection are given. Diabetic ketoacidosis is an acute, major, life-threatening complication of diabetes characterized by hyperglycemic ketoacidosis and ketonuria. It occurs due to a relative insulin deficiency which inhibits ability of glucose to enter cells for utilization as metabolic fuel, causing liver to rapidly break down fats into ketones for energy generation. The overproduction of ketones results in its accumulation in blood and urine, turning the blood acidic. Diabetic ketoacidosis or DKA mainly occurs in type 1 diabetes mellitus, as the presence of insulin in type 2 diabetes mellitus prevents the breakdown of fats, but sometimes it can occur in type 2 diabetes mellitus as well. The clinical manifestations include hyperglycemia, metabolic acidosis, nausea, abdominal pain, fruity breath, electrolyte loss. The patient can also develop Kussmaul's breathing, which refers to the increased depth and rate of respiration due to acidosis. Treatment of diabetic ketoacidosis includes 0.9% normal saline infusion with regular insulin to correct dehydration. Monitoring for potassium level closely because level may fall rapidly within the first hours of treatment. Hyperglycemic hyperosmolar non-ketotic syndrome is a metabolic complication of diabetes mellitus characterized by severe hyperglycemia, extreme dehydration, hyperosmolar plasma, and altered consciousness. It most often occurs in type 2 diabetes mellitus. The precipitating factors include acute infections and other medical conditions, medications that impair glucose tolerance like glucocorticoids, or increased fluid loss, diuresis, non-adherence to diabetes treatment. Serum ketones are not present in HHNS as the amount of insulin present in most patients with type 2 diabetes mellitus is adequate to suppress ketogenesis. HHNS is treated with 0.9% normal saline to correct dehydration, correction of hypokalemia by potassium infusion, and insulin to regulate blood sugar levels. Diabetic coma is the coma resulting from extremely low or extremely high blood sugar levels, although hypoglycemia is much more common. Now we come to the management of diabetes mellitus. In this, we have non-pharmacologic management and pharmacologic management. Dietary management includes advising the patient to take low sugar diet. The distribution of calories is as 50 to 60% carbohydrates, 15 to 20% proteins, and 20 to 30% fats. Diet should be containing soluble and insoluble fibers. Soluble fibers decrease cholesterol level and blood glucose level, and insoluble fibers inhibit constipation. The next comes the exercise. Exercise lowers blood glucose level and improves cardiovascular fitness and muscle tone. Exercise helps reduce weight, insulin resistance, cholesterol, and triglyceride level. The patient must make sure to monitor blood glucose level before, during and after the exercise to avoid any untoward incidents. Patient should perform exercise at the same time of the day and when blood glucose level is at peak after the meal. Exercise should be avoided if blood glucose level is more than 250 mg per deciliter and ketones are present in urine. The patient should also avoid smoking as it increases risk of microvascular complications and cardiovascular disease. Pharmacologic management of diabetes mellitus includes oral hypoglycemic agents and insulin. Oral medications are prescribed for patients with type 2 diabetes mellitus when diet and weight control therapy have failed to maintain satisfactory blood sugar levels. Oral hypoglycemic agents increase the number of insulin receptors on cell surface to enhance insulin action. There are various classes of oral hypoglycemic agents like biguanides, metformin, second-generation sulfonylureas, glimepiride, glipizide, meglitinides, netiglinide, repaglinide, and so on. Metformin should be discontinued 48 hours before any surgery and other long-acting oral hypoglycemic agents before 24 hours of surgery. Insulin is mainly used to treat type 1 diabetes mellitus. It is also sometimes used to treat type 2 diabetes mellitus when blood sugar levels are not adequately controlled with oral hypoglycemic agents. Insulin acts primarily in liver, muscle, and adipose tissue by attaching to receptors on cellular membranes and facilitating the passage of glucose, potassium, and magnesium. The onset, peak, and duration of insulin action depends on its type. The first type is the rapid-acting insulin, for example Lispro, with onset of 15 minutes, peak of 30 minutes to 2.5 hours, and a duration of action of 3 to 6 hours. Next, we have short-acting insulin like regular insulin, with onset of 30 minutes, peak of 1 to 5 hours, and a duration of 6 to 10 hours. Then we have intermediate-acting insulin like NPH, with onset of 2 to 4 hours, peak of 6 to 14 hours, and a duration of action of 16 to 24 hours. Lastly, we have long-acting insulin like ultra-lent insulin, insulin glargine, with onset of 2 hours, peak of 12 to 24 hours, and a duration of action of 18 to 24 hours. Only regular insulin can be given through intravenous mode and therefore can be used in emergency situations. Regular insulin can be mixed with any type of insulin. Insulin glargine is not mixed with any other type of insulin as its pH may get altered. A 27 to 29 gauge needle is used for insulin injection. The insulin is administered subcutaneously at 45 to 90 degrees angle in normal-sized clients and 45 to 60 degrees angle in thin clients. Insulin should be kept in a cold place. Avoid freezing and direct exposure to sunlight. Before injection, the insulin should be at room temperature. The sites for the insulin injection include upper outer arms, abdomen, upper outer thighs, and upper buttocks. There are several side effects of insulin therapy. Some patients may develop local allergic reactions like redness, swelling, tenderness, induration at the site of injection. It usually develops 1 to 2 hours after administration of injection. Insulin lipodystrophy is the development of fibrous fatty masses at the injection site by repeated use of same site. To avoid this, patient is advised to avoid injection at the affected site and to rotate the injection site. Another side effect is the dawn phenomenon, also known as the dawn effect. Dawn effect is an increase in the blood glucose level in the early morning, usually between 5 and 8 a.m. This effect happens due to excessive secretion of growth hormone and cortisol, which cause a reduced tissue sensitivity to insulin. Treatment of dawn phenomenon includes an increase in the client's insulin dosage or a change in the time of insulin administration. Also, the patient is advised to avoid having carbohydrates before going to bed. Next, we have the Somogyi effect or Somogyi phenomenon, which is rebound hyperglycemia following an episode of hypoglycemia. Hypoglycemia occurs at about 2 to 3 a.m., which causes an increase in the counter-regulatory hormones like glucagon, cortisol, and thyroxine, which causes increased blood sugar levels at around 7 a.m. The patient may complain of night sweats, early morning headaches, and nightmares. Treatment includes a decrease in client's insulin dose and an increase in bedtime snacks or both.